Thanks for coming to tonight's webinar. I'm Dr. Nicole Hope, and tonight with Professor Martin Healy, we are talking about my first IVF cycle and what to expect. During the webinar, if you have any questions, please submit them electronically, and at the end of the webinar, Martin and I will do a Q&A session and answer all your questions. Also, during tonight's webinar, Martin and I will intermittently be talking about COVID, what we're doing at the clinic, what to expect, and the changes related to COVID. So that will be covered during the talk as well. So without further ado, I'm going to hand over to Martin, and he's going to talk about, do the first half of the talk. He's going to be talking about medications and the egg collection, and I will let him explain what he has to say. Thank you.
Thanks very much, Nicole. I'm Martin Healy. I am going to really start at the beginning, hopefully, and just give me 2 seconds while I get myself organised with our presentation. So, here we go. Magic. So the main focus of tonight's talk is about coming into your first IVF cycle, and that is a new experience, and for some people that's scary, for some people it's exciting because you feel like you're finally moving on. Listed here are the sorts of topics that we're going to be covering, and in amongst it, we're also going to be trying to give you a bit of a feel about how all this stuff that's going on with COVID is impacting on what's happening, and specifically how it's going to affect you as you go through your first IVF cycle. Now, doing an IVF cycle, as per this slide, is a little bit on the complicated side. There's a whole bunch of things going on, and I don't want you to try and memorise them all from this slide. My job and Nicole's job is to try and make things simple. So the first thing is, when we're starting a cycle, we tend to, wherever possible, look at giving you fairly simple numbers. So we usually start a cycle talking about day 1, which is the first day of your period. So first day of your period is a useful marker, and we use that in a lot of the cycles we do. We are going to talk about stimulation, what we do for getting you going, and how we trigger the maturing of your eggs, how we collect your eggs, fertilise them, the growth of your embryos, the transfer of your embryo, and then the waiting, will it happen, pregnancy test, and then if it doesn't happen, where we go next with your next cycle. So I'll start off really focusing on the initial stimulation and where we go from there. So with the initial stimulation, what are we trying to do? And the answer is, we're trying to get your body to do something it doesn't normally do. So normally each cycle, your body will release one mature egg, and you'll either get pregnant or not get pregnant. When we're doing IVF, we're trying to get your body to not just release one egg, but release as many as we can make you release, but within sort of some restrictions. We don't want to have you releasing huge numbers of eggs, because sometimes that can lead to you getting sick with a condition called ovarian hyperstimulation syndrome, which you may well have already heard about. To do this, we need to keep an eye on what's going on, and so we monitor you, because we want it all to go safely. We want you to come out the other end of this with lots of eggs, which then make several embryos, but you to be well and healthy at the other end without any problems. So with the stimulation, we're really trying to get you to make many eggs, and the way we do that is with injections of a natural hormone called FSH that your body normally makes to help you develop and grow eggs. But at the same time, we don't want your body releasing the eggs at any old time. We want your body to release them when we're ready, so that we can steal those eggs before your body actually releases them. And so we use a couple of different drugs, either what's called an antagonist drug or an agonist drug, to try and stop your body releasing your eggs until we're ready to do a snatch and grab. There's a few different stimulation types that we use. Historically, people used to use quite frequently or almost exclusively downregulation agonist cycles. They're still used occasionally, but not nearly as frequently. Flare boost agonist cycles, again, we use quite frequently and have become less common, but are still used in certain circumstances. But the most common cycle we use nowadays is an antagonist cycle. And this is a simple cycle from the point of view of the use of the drugs. It's generally simpler for you as the patient, and it's a more flexible cycle from our point of view. So what happens? Day one. So as I said, day one is the first day of your period. You record that that's day one, and then you may or may not contact your IVF nurse to let them know that things are starting and that you're about to commence your cycle. The next day, so day 2 or day 3, you start using injections of the FSH hormone, and these are usually given in the evening. It's a once-a-day injection, and either you can inject yourself or your partner can if you're uncomfortable with use of needles. The injections are given into the fat, usually of your abdominal wall, occasionally into the thigh. Does it matter which brand of FSH injection you use? The answer is no. There have been lots of research done that hasn't been able to show a particular benefit of one form of FSH over another. Now, all the companies that sell it will like to say theirs is best, but bottom line is it doesn't make a difference. So you start using your FSH injections from day 2 or 3 every evening. Around about day 5 or 6 usually, we will start you on injections of the drug to block you releasing the eggs yourself, the antagonist. And this is either a drug called Cetrotide or Galutron. And these injections you have in the morning rather than the evening, same area into the tummy wall or into the thigh. Now, occasionally people will have a slightly different way of doing things. And so instead of just starting day 5 or 6, in some situations we will instead do an ultrasound day 5 or 6 and only start the antagonist injections when we can see that you have at least one follicle over 14 millimetres. And this is what's called a flexible start cycle. So antagonist is to stop you releasing your eggs sooner than we want you to. Commonly, we do a fixed start, which is starting the injections day 5 or 6. So what about the monitoring? So we then wait, and usually around about day 9, 10 or 11, we will get you to attend to have some blood tests, and that'll be a single blood sample removed where we test your estrogen level, your progesterone level, and a hormone called LH. And at the same time, we get you to have an ultrasound. And what we're trying to see is how many follicles you've grown, how big they are, and are you ready for us to mature your eggs and have your egg collection, or do we need to keep waiting a little longer? So the outcomes of this sort of initial monitoring assessment is, option 1 is we may look and say, yep, everything's going well. It's time for us to organise the trigger. So have your trigger sometime tonight or tomorrow night or the night after. Here is the time to do it. And we will give you an exact time, which will be either on the hour or every half hour. The second thing that might happen is we look and we say, well, either we want to increase your FSH dose or reduce your FSH dose, depending on what is going on, and keep you going for a little longer. The third thing that could happen is we could look and say, you're making heaps of eggs. This is a bit worrying about this ovarian hyperstimulation syndrome condition. We need to have a chat, and we want to change what sort of trigger we're going to use for you. So with the view that any embryos we get, we're going to want to freeze them and not want to put one back so that we don't make you sick. We may look and say, okay, we need to do another ultrasound and repeat bloods in 2, 3 or 4 days' time because you're making progress, but you're not quite there yet. Or occasionally we'll turn around and say, we're very unhappy, either you've done nothing, we want to stop and start again with a higher dose of your FSH. Or the other extreme, you've done way too much, you've got heaps and heaps of eggs, this is dangerous, we shouldn't even go any further, stop the injections and let's let everything calm down. So we've done the monitoring, we've got to the point of saying, yep, it's trigger time for you. So your IVF nurse is going to say to you, here is the time that you're going to need to take your trigger. And it might be quite a weird time, like it might be 2 o'clock in the morning or 10 o'clock at night or something like that. We're not idiots, it has been worked out right. So you need to take your trigger at exactly the time you've been told. If it's 5 or 10 minutes late, then that's not the end of the world, but you need to do it at that time. What the trigger injection is going to do is it's going to start your eggs maturing and get them ready to be released. And your eggs will be released somewhere between 38 or 40 hours after the trigger injection, and we're going to steal your eggs usually about 4 hours before they're ready to be released. There's two sorts of triggers. The first are triggers that mimic the hormone that you release naturally, called Pregnyl or Ovidrel. And the second group of triggers don't mimic it, but instead they cause a surge release of the natural trigger LH and get you going. Now, we're in a stage where COVID seems to have taken over the world, and I'm specifically not wanting you to feel like this is just to talk about COVID, but it has had an impact on IVF. Fortunately, as opposed to with the first sort of shutdown that happened earlier in the year, this time around we haven't had any great restrictions on the IVF process, but we do still need to take precautions. And so as part of that, you need to be aware that if you're going to have an egg collection, having a COVID swab prior is mandatory. And so what the nursing staff will normally do is they will communicate with you as they're working out when you're going to be likely to have your trigger. They'll be working out when you need to have your COVID test done so that you've had adequate time for the results to come through in time for you to be admitted for your egg collection and to go from there. Now, it's very important to understand, though, that once you've had your COVID test done, that you then need to isolate. So the nursing staff will say, okay, do the COVID test on this date at this time, give or take a while, and then in the future, a day or 2 or 3 later, here's when you have to have your trigger injection. But from when you've had the COVID test done, you have to go home after that test. Don't go anywhere else. You don't leave your home after that, even for exercise, and you've got to separate yourself in the house from others that live in the house. Be in a separate room, use separate bathroom if possible, stay away from people, practice good hygiene, and don't be sharing food, drinks, cups, plates, cutlery, or beds. With the egg retrieval, you come into hospital fasted, you have a light anaesthetic, and the timing is really important. And so it's essential that you don't be late. So if you're told to turn up at sort of 7:30 in the morning, we mean 7:30. We don't mean country time, 9:30. So you turn up on time. All our egg retrievals are done at the site we have in the Akira building at Box Hill. And you have an anaesthetist there who gives you either sedation or a light anaesthetic. The taking of the eggs takes about 15 to 20 minutes. And what's involved is we use an ultrasound through the vagina and stick a very fine needle into each of the follicles in your ovary and suck out the eggs. Usually you're right to go home about an hour, hour and a half later, and it usually takes a day or 2 to get over it. Most people will experience some lower abdominal discomfort or pain and will have a bit of bleeding vaginally from where the needle's gone through the wall of the vagina. It's really important to not have unrealistic expectations. So if you've had an ultrasound done as part of your monitoring that says you've got 10 good-sized follicles, and here we talk about follicles over 11 millimetres across, 10 follicles could give you 5 eggs. It could give you 8 eggs. it could give you 10 eggs, or a couple more might have grown and you could get 11 or 12 or 13. But it's not an exact measure. The monitoring gives us an estimate, a sort of an approximate, but you should not get set in your mind, I've got 10 eggs. They said I've got 10 follicles, so therefore I've got 10 eggs. It doesn't work that way. It's much more inexact. I'm now going to hand over to Dr. Nicole Hope, who's going to take you forward from here. You've had your eggs collected, and now it's over to her.
Thanks, Martin. So I'm going to be talking about what happens in the second half of the cycle, namely fertilising the eggs, culturing or growing the embryos in the lab, and finally doing the embryo transfer. So you'll be happy to know that the trigger injection is usually the last injection that you have during the cycle. But nonetheless, if you are having a fresh embryo transfer, usually you do need a little bit of extra hormone support in the form of progesterone. Unfortunately, taking progesterone orally, like in a tablet, doesn't seem to work that well in an IVF cycle. So usually we are giving you something that you insert vaginally, which we call a pessary. There are some tablets and some creams which you can insert vaginally as well. If you think this is going to be an issue for you, then you should let your doctor know and they can speak to you about alternatives. Generally, you're starting your progesterone luteal phase support the day after your egg collection. So the day you have the egg collection, we call this day 0. We get the eggs, we get the sperm, and then we need to put the eggs and sperm together, and that's called insemination. We have 2 main ways that we can put the egg and sperm together. The first way is called conventional IVF, and the second way is called microinjection or ICSI. Sometimes the sperm is fresh. Often we ask your partner to produce the sperm sample on the day, and then you bring that sample in with you when you come for the egg collection. But sometimes we have sperm that's already been prepared and frozen in advance, and we can use that as well. Fertilisation actually takes place over many hours, so we don't know how many eggs have actually fertilised until the next morning. So conventional IVF is where we get the sperm, we prepare it, and we place the sperm right next to the egg in the Petri dish, and we let fertilisation happen naturally. When men have really good quality sperm, we think that this is the ideal way to go. It allows fertilisation to happen naturally with less manipulation of the egg. There is an occasional incidence of eggs that don't fertilise, and your doctor will speak to you about that risk. It's also important to consider if this is the right thing for you. If you are doing pre-implantation genetic testing, there are some forms of testing which do require ICSI. However, if you are doing routine PGT with chromosome testing, usually we can do that with the conventional IVF. Microinjection, or ICSI, is where we actually go through the sperm and we try and pick sperm that look normal and are swimming normally, and we inject a single sperm into each egg. This is really helpful when men have very low sperm counts or poor swimming or low normal shaped sperm, and then we can try and select the best possible sperm and inject the sperm into each egg. ICSI can be used with all types of pre-implantation genetic testing. If you have had particularly poor outcomes related to fertilisation, sometimes we do offer some advanced techniques to try and select the best possible sperm, and usually we are doing this in conjunction with ICSI as well. So as I mentioned, fertilisation takes place over several hours. So even though we know on the day of egg collection that we have sperm and we've put the eggs and sperm together, we don't know until the next day how many of the eggs have actually fertilised. So the next day after egg collection, this is called day 1 after egg collection, and usually you're going to get 2 phone calls. The first phone call is from the embryologist, and they're going to let you know the fertilisation results. Generally, we would expect 2 out of 3 mature eggs to fertilise. Now, I do stress mature. Sometimes when you have your egg collection, you might be told when you're leaving that you've had 10 eggs collected. So generally, if they're 10 mature eggs, you might hope that you get 6 or 7 of those eggs fertilising. However, sometimes when we look at the eggs after your egg collection, we might see that some of the eggs are not mature, and unfortunately those eggs won't fertilise. So we're expecting 2 out of 3 mature eggs to fertilise. As I mentioned before, sometimes we do find out that the eggs haven't fertilised, and this probably happens in less than 5% of cycles. There are some groups of people where it may be more likely to happen, and that's something to discuss with your doctor when you're planning your treatment. You will also get a phone call from the IVF nurse. The IVF nurse is calling you because you've just had your egg collection the day before. They want to check that you're feeling okay, that you're not having too much pain, you're eating and drinking, and they're also going to remind you to start taking your vaginal progesterone. Once we have the embryos that have fertilised, we are then culturing or growing them in our embryoscope. So the embryoscope is an incubator, and it takes images of the embryos every 5 to 10 minutes. It's a closed system. So what that means is the embryos can grow happily in the embryoscope. We don't have to keep pulling them in and out of the incubator to have a look at them. We can then review the images and see how the embryos are growing. It means we can look at the embryos anytime, and also because we are recording the images, we can also look back and see what's happened, for example, overnight when we were in the lab, and we can monitor the embryos as they're growing. We then, I think we might have missed one slide, actually. Sorry. Okay, the next update you get after fertilisation is on day 3. And again, you'll usually get a call from the embryologist and also from your IVF nurse. The embryologist is going to give you an update on what's happening with the embryos. So at the day 3 stage, we're expecting the embryos to be somewhere around the 6 to 8 cell stage. Sometimes there may already be some embryos that are lagging or have stopped growing at that stage, and the embryologist is going to tell you about that as well. The IVF nurse is also going to call you and give you some details about your upcoming embryo transfer. So they're going to let you know what time you have to come and what you need to do to prepare. So if you are having an embryo transfer, generally we are doing this on day 5. And usually at that stage, we are hoping that we have what we call a blastocyst embryo to transfer. Sometimes if there is more than one good embryo, we might transfer one embryo back into you, and there might be some additional embryos that we might freeze. Sometimes if they are advanced enough, we may already freeze those embryos on day 5. Sometimes the embryologist might grow the embryo for an additional day and reassess and freeze on day 6. So when you come in for your transfer, we don't always have the final numbers of how many embryos we're going to freeze. Likewise, if you're having pre-implantation genetic testing, the embryos may get biopsied on day 5 or they may get biopsied on day 6. Sometimes, unfortunately, there are embryos that look like they may still have potential on day 5, but when we reassess them on day 6, they may not have survived, and then those embryos we do discard. And so you will also get another phone call from the embryologist on either day 6 or day 7, just to give you a final update on how many embryos you had frozen from your cycle. So what does the embryo transfer procedure involve? Well, I generally say to patients, it's like having a pap smear. You come into a room, we get you up onto a bed, it has some stirrups and you put your legs in the stirrups. We insert a speculum like you're having a pap smear, and then we put a little tube into the cervix, into the uterus, and we push the embryo in. It takes about 5 minutes. Unless you have problems with pap smears, we don't usually need an anaesthetic for this. We do need you though to have a full bladder so we can get a really good picture of your uterus when we're doing the ultrasound. Before you actually have the embryo transfer, you sit down with our embryologists and they are going to show you a video of your embryo and how it's grown and give you that update on what's happening with the other embryos. As I mentioned, we use an ultrasound to make sure we're positioning the embryo in the correct place. But once the embryo transfer is done, which as it says earlier, it's very quick, 5 minutes, you are free to leave, go back to work or go home or wherever you're going next. So who's actually going to be in the room at the time of the transfer? Well, there is the doctor, and the doctor is the person who actually does the embryo transfer. There is a nurse, and the nurse will be assisting with the ultrasound scan that you have during the transfer. As I mentioned, the embryologist will be there in the room. Initially, they are in the lab preparing the embryo to make sure it's ready for transfer. They will then come and sit with you and show you a video and discuss the embryo development, and then when the actual transfer is happening, they bring the embryo into the room and hand that to the doctor to insert into you. Prior to COVID, we often did have partners come into the transfer room and be part of the whole process, but unfortunately at the moment, only the person having the transfer is allowed in the room. So you may have heard of embryo glue. This is a viscous liquid that may help embryos to implant, and we routinely use this at the time of embryo transfer. We actually put that fluid in the tube that is where your embryo is when we inject it in. So you are not having to buy embryo glue yourself or insert embryo glue yourself. That's just something we do in the lab, and it automatically happens when we go ahead with the transfer. We don't charge anything extra for doing the embryo glue. It's a routine part of procedure. You don't have to ask for it, but it will happen on the day, so you can be comforted that that's all going on in the background. For those of you who are having pre-implantation genetic testing, you may or may not be having a fresh transfer. But as I mentioned before, we usually do this genetic testing on day 5 or day 6. We want the embryo to be at a blastocyst stage and to have lots of cells so that we can safely remove a few cells to do testing on. If you are having PGT, we don't necessarily do the testing until day 6. So you will get a phone call, as I mentioned previously, on day 6 or day 7 to let you know about the final numbers of embryos that have been able to be tested and frozen. It then takes up to 3 weeks to get a result from the genetics test. Even with COVID happening, we are still getting our results back in the same amount of time that we always have. When the results come back, someone from our genetics team is going to give you a call and give you your results and discuss them with you. So if you have had an embryo transfer, you are, as Martin mentioned earlier, now in the hard part of the cycle, which is waiting for that pregnancy test. We scheduled the pregnancy test for roughly 2 weeks after your egg collection. When you come in for your embryo transfer, you will be given a sheet of paper which has your request form to do the pregnancy test and also the instructions on what day you should be having it done and where you need to go. We don't routinely call people regularly during the time between the transfer and the pregnancy test. However, you are welcome to call us at any time. We want you to call us if you're in pain or you're having bleeding or you're having side effects with your medications, or even if you just need some emotional support or to talk to someone about what has happened, because that time in the cycle is a bit tough while you're waiting and you're obviously anxious and nervous. So we are here for you even if we're not ringing you every day. So when you do your pregnancy test, you usually do this first thing in the morning, and usually we get the results by the afternoon and the nurse will call you. If you are pregnant, it's usually a big relief and fantastic news. The nurse will then talk to you about monitoring over the next few weeks. We normally do a blood test again the next week, which is when you're 5 weeks, and then the following week at 6 weeks, and then you have an ultrasound at 7 weeks. And at 7 weeks, we hope to see a baby and a heart rate, and we confirm your due date at that time. Usually when you find out you are pregnant, your IVF specialist is also notified and they are getting in touch with you about the monitoring, and also to discuss what your plans are for pregnancy care, which could involve referring you on to an obstetrician. Unfortunately, though, not everybody gets good news with their pregnancy tests, so it's also important to plan for what happens if you get a negative or an equivocal pregnancy test. So what equivocal pregnancy test means is that when you do your pregnancy test, the result is positive, but the hormone level isn't as high as what we would expect. Unfortunately, if you have a low positive pregnancy test, we know that there's a much higher chance of miscarriage or the pregnancy not continuing. So often, instead of just doing another blood test a week later, sometimes you might have a blood test earlier, or you might have an ultrasound earlier, but you might find you are monitored more intensively if you do have an equivocal result. Some patients, though, their result is completely negative. There's no pregnancy hormone there at all. Usually at that stage, we would like you to make an appointment with your doctor to talk about what to do next. If you have frozen embryos, that might be planning to do a frozen embryo transfer. If you have if you don't have any frozen embryos, then it might be planning a new IVF cycle. In certain circumstances, it can be appropriate to go ahead with a new IVF cycle straight away. So if that's something you're keen on doing, it's important to let the nurse know so that they can discuss this with your doctor and make a plan so that you can commence treatment sooner rather than later. So in terms of preparing for the next cycle, we do recommend having a review appointment with your IVF doctor. It's good to review the results, look at how many eggs you had collected. Was that what you were expecting? Could we get more? How was the fertilisation? Was it what we were expecting? Can we do better? And looking at points during the cycle to see where things went well or maybe things that we could improve upon. The doctor will talk to you about the medications. Do we need to adjust the medications you're on? Were you having side effects? Is there something that might work better for you? And sometimes during an IVF cycle, other things can come up. You may have an ultrasound. It may show that there's a polyp, and we might be discussing removing a polyp before we go ahead with further IVF treatment. So these are all the things you talk about in that doctor's appointment. So obviously, as Martin was saying, COVID has taken over the world and we have all had to adapt. Patients are worried that because of COVID, they may not be able to leave the home, but because this IVF is medical treatment, it is acceptable to leave home, to have ultrasounds and blood tests, to come and have your egg collection or your embryo transfer, and also for men to produce sperm. With the sperm production, we really are encouraging our men to try and produce at home and to bring the sample in where possible. We will also provide documentation so that if you are pulled over and you need to show evidence that you're travelling for medical care, that you're able to do so easily. As I mentioned earlier, with the embryo transfer, unfortunately, partners are not allowed to come in for the procedures at the moment, which is disappointing. But we do have these videos that we take of the embryos, and we are happy to email them to you, and you can share the video with your partner when you are home. So what are we doing at New Life to try and prevent COVID? We are minimising the number of people coming to the clinic. So we are doing more of our appointments via telehealth. Our consent forms we're doing electronically. Even our staff, we're minimising number of on-site staff. So a lot of our staff are actually working from home. Everybody is wearing masks, and occasionally we're also wearing masks with shields as well. You'll notice there's copious amounts of hand sanitizer through the clinic. When you do have contact with the clinic, you'll notice you get asked a lot about whether you have any symptoms of COVID or any risk factors. And when you come in for your procedures, you do have a temperature check at each visit so we can make sure you don't have a fever. We regularly clean the clinic. We are paranoid about social distancing, and we make sure, even with patients sitting and waiting in our waiting rooms, that we only have a maximum of 2 people at any time and they are spaced apart. And as Martin mentioned, we are having patients doing COVID swabs before their egg collections. So now is the time for questions. Hopefully you've submitted some. So to make a question or to submit a question, you have to click the questions button in the Zoom app, and then you type away, and then we will answer them. We did have a couple of questions submitted earlier. So one of the questions was from someone who has a low egg number, and they were asking if they do IVF and have their eggs collected, does it reduce their ovarian reserve? So even though you have a set number of eggs, each month you have a little batch or a cohort of eggs, and they're the eggs that are available for us to collect that month. If we don't collect those eggs are going to disappear anyway. So in the IVF cycle, we will take as many eggs as we collect, and that's not going to reduce your overall egg supply. And as I said, if we didn't take those eggs would have disappeared anyway. So you can be rest assured that if you are someone who does have a low egg number, you are not going to decrease your chances or run out of eggs earlier because you've had IVF treatment. Next question is, if my partner is bringing in his sperm sample, what does he bring this in with? So we are just happy with a normal kind of specimen collection jar. You might be familiar, they're like a plastic jar with a yellow lid. You can get them from a pathology clinic, from a pharmacy, from your GP. It doesn't have to be a sterile sample. Next question, there's one about, what's this one? Oh, how many injections will I need? That's a good question. So when typically people are taking injections for about 10 days, initially there is the follicle stimulating hormone injection that you take at night, which is to help the eggs grow. And so you might be taking that one for 10 days. After you've taken medications for a few days, you might then start your morning injection, which, as Martin was explaining, is the antagonist injection. So you might be doing the nighttime injection for 10 days and the morning injection for 5 days, and then the final injection, which is the trigger injection. So I would say around 10 days of injections. On about half of those days, you're just doing 1 injection a day, and the other half of the days you'd be doing 2 injections a day, 1 in the morning and 1 at night. I might now hand over to Martin.
So next question, how many days off following an egg collection? So usually we look at the egg collection as being like a small day case procedure where you're having an anaesthetic. And so generally after an anaesthetic, we'd be recommending you don't do anything major for 24 hours. And so we'd normally be expecting you to have the day of the procedure and the next day off from work and from driving and doing major things. The further question that followed on from this is there a lot of pain? And the answer is this varies. Occasionally people do get a lot of pain, but the vast majority of people don't. Most people, it's more like I'm uncomfortable or I'm a bit sore, and usually Panadol is enough to settle things down. Question after that is, do we get to keep the embryo video? And the answer is yes. If we send you the embryo video, it's yours. We don't ask for you to send it back. And the final question on the list that's being shown to me, separate from the one that's on the screen, is, will my doctor do the embryo transfer? And the answer for that one is sometimes yes, sometimes no. We have a roster of, for the doctors in the clinic. So we've got 5 doctors currently in the clinic working, and so we have a roster, and on any one day the doctor who's on that roster for that day does all the egg collections and all the embryo transfers. And so if you happen to be having your egg collection or transfer on the day that your specialist is rostered, then yes, you have your specialist. But if you're on one of the other 4, on one of the days with the other 4, no, you'll be seeing one of the other people in the team. Sadly, everyone in the team's really lovely. And so they're all very nice people. So it means that you get to meet some really nice people along the way, other than just your own specialist, who is also nice. So enjoy finding out who else is part of the team, because there's some fantastically nice people that you'll come across. I'm now going to hand back to Nicole for some more questions.
Thank you. So there's a question for the embryo transfer. If anaesthetic is given, is it local or general? So generally we are not giving anaesthetic. If someone does elect to have an anaesthetic, it's not a full general anaesthetic, it's more like sedation. So you shouldn't remember what's happened, but you won't be aware of the procedure. If you don't want to have a full anaesthetic, sometimes it's possible to give a sedative, for example, some Valium prior to the embryo transfer, and that may help someone relax enough to go ahead with the transfer awake. But again, that's something to discuss with your doctor. Another question is, do fibroids affect implantation? So the answer is some fibroids may, but not all fibroids. We generally know that the larger the fibroid, the more of an impact it may have. And also, if a fibroid is in a particular location, it may also have an impact. So I think with regards to fibroids, it's very individual. Someone can have a large fibroid, but if it's in a position that's not really pushing in on the cavity of the uterus, it may not have that bigger an impact, whereas someone else can have a smaller fibroid, but it's in a position that may cause problems. So I think with the fibroids, the best thing to do is to go through your ultrasound with your doctor and see if your fibroids are likely to cause a problem. Next question is, what is the genetic testing for and who requires this? So genetic testing is an optional part of the IVF treatment. A lot of women do what we call chromosome testing, which is to look for abnormal chromosomes such as Down syndrome in the embryo. So unfortunately, as women get older, we are more likely to produce abnormal eggs, which result in abnormal embryos, which can then either result in not getting pregnant or having a miscarriage, or potentially having an abnormal pregnancy that we may need to think about terminating. So some women are doing the genetic testing to look for these chromosome problems, and they may be doing this because they are older and at increased risk of these problems. But we also do genetic testing for specific genetic conditions. We are usually only doing that if there's a known genetic condition. So unfortunately, we're not at the stage yet where we can just do a random screen of all your embryos and test for every single genetic condition. But if you know that you're a carrier for a genetic condition like cystic fibrosis, for example, then we can assess you and potentially do testing on the embryos and make sure we're not transferring an affected embryo back into you. I might hand over to Martin for some more questions.
The next question is, what can make the body not accept the pregnancy after embryo transfer? Are there things to increase the chance of success? That's a really good question, and it's a question that we don't know nearly as much about as we'd like to pretend. So when we put an embryo back into the cavity of the uterus, there's some form of interaction that occurs between the embryo and the actual lining of the uterus or the endometrium. It's complicated. We don't understand it all that well. There are certain things that can make it a lot less likely that an embryo will stick, implant and grow. So if the lining's really thin, if someone's got an infection in the uterus, if there's a big polyp in the cavity of the uterus, if the timing's wrong, all of these things can make it less likely that an embryo will stick. So there's lots that we do know, but there's a lot more that we don't know, because if you think about it, not all of the embryos that we put back stick, and not all of them have an obvious answer there. So there's plenty more still to learn in this area. Next question is there anything you would do differently in preparation for an IVF cycle if you have endometriosis but have had removal surgery recently? The answer to that is no. Endometriosis itself, it's still unclear to us whether or not treating it prior to IVF is beneficial or makes no difference to the IVF success rate. And so I think if someone's having surgery for endometriosis prior to IVF, it's uncertain in many people's mind as to whether this is actually going to change the outcome. I guess the only thing we would do is most people would like to have a bit of a gap in time between the surgery and doing IVF so that any sort of healing inflammation has a chance to settle down. Do you recommend genetic carrier screening prior to IVF treatment? Recommend's a strong word. We offer and we routinely through New Life IVF do genetic carrier screening for the 3 most common genetic conditions that can be detected by sort of testing. So that's cystic fibrosis, which Nicole mentioned earlier, a condition called spinal muscular atrophy, and Fragile X. We do this so that people can be informed. And so if one person in a couple happens to be a carrier for a condition and the other doesn't, then it's generally not an issue. But if both people in a couple have carrier status, then we consider that it's important that they at least know about it so that they're aware that there is a risk that they could have a baby with this particular condition, and therefore have the opportunity, if they wish, to do genetic testing. Now, the difficulty is that there are literally hundreds and thousands of rare genetic conditions that can be tested for. And there's always the question of how many tests do you do for how rare conditions. And I don't think we've got a right answer to that question so far. The next question is, what are the reasons for failed implantation? I think I've kind of covered some of the answers to that sort of 2 or 3 questions ago, so I might move on from that. Next question, does endometriosis impact IVF success rate? The answer to this is, if you've got mild endometriosis, probably not. So with people with mild endometriosis, IVF success rates seem to be fairly similar. But if you're looking at people who've got severe endometriosis, particularly people who've got sort of large cysts of endometriosis having an impact on their ovaries and how many eggs they've got, there does seem to be a difference, and that the success rates seem to be lower in that group. I'm going to hand back to Nicole and she'll carry on.
Okay. Are the self-administered injections foolproof, or can you mess it up? The IVF injections are generally in these pen devices, and they are designed for people who are not medical. So they are really easy to use. I won't say that they're completely foolproof. I've definitely had lots of phone calls at night with someone who's feels they haven't done their injection correctly or something may not have gone right. Most of the time, as long as you ring your doctor and get some urgent advice, situations can easily be sorted out. It's very unusual that if someone's done everything correctly, that the medication would fail or it wouldn't work. Usually it's related to having not done the injection properly, and most people are aware that they haven't. And as I said, as long as you ring your doctor and let them know what's happened, then they can either reassure you that everything's okay, or maybe give you some advice about what to do if it hasn't gone smoothly. The next question is, it says it takes 3 weeks for genetic results to come in. Does that mean the genetic testing is only done on the embryos that will be frozen, not on the one that's transferred fresh? That's exactly right. It actually does take time to get the results back from the genetic testing. So if you actually have a known genetic condition you're testing for, like cystic fibrosis, and obviously you don't want to transfer an embryo that might be affected by that, so in that situation you would have your egg collection, we would freeze any suitable embryos, and then we would wait the 3 weeks to get the results back before we go ahead with an embryo transfer. If, however, you are maybe doing a general screening, checking the chromosomes just because you're a bit older, in that situation, you may elect to transfer a fresh embryo which has not had testing, and then only do the testing on the embryos that you have frozen. Next question is, are there any barriers to commencing an IVF cycle, for example, age or weight? With regards to age, we generally don't let you do a stimulated IVF cycle once you're 46. So that means in terms of collecting your own eggs, it needs to be done before the age of 46. We will, however, let you do a frozen or an embryo transfer up until the age of 53. That might be with your own embryo that you created when you were younger, before 46, or it could be with an embryo created from a donor as well. In terms of weight, we do have some weight restrictions. Generally, we are working on BMI. So when you do start your cycle, the nurse will ask you your height and weight and calculate your BMI. If you are within the range, we can usually go ahead. If you are above the range, we will review your situation. Sometimes we may need you to lose some weight before we can begin treatment, but we also discuss each case individually with the anaesthetist and determine if it's safe to proceed. What are the general success rates at New Life IVF? With success rates, I think it is hard to give those success rates because the success rates vary according to age. So in a younger group, you're going to have much better success rates than in an older group, and that's normal. What I can say that for women less than 35 years, we have about a 43% chance of clinical pregnancy per embryo transfer, fresh embryo transfer. So that's in the younger age group, but as you get older, unfortunately, the pregnancy rates do decline. And so when you look at pregnancy rates, it's important to speak to your doctor and get an accurate reflection based on your age. And now I'll hand over to Martin for some more questions.
Next question. I have a dermoid cyst on my ovary. Does this affect IVF at all? The answer is a little bit yes. So if you've got a dermoid cyst in your ovary, then when we're doing the egg collection, we've got to work our way around the dermoid cyst with the needle that we're using to try and collect the eggs from your ovaries. And so as a generalisation, if the cyst is more than, say, 2 to 3 centimetres across, we would normally recommend that you have it removed prior to doing IVF, just to make the actual process of egg collection that little bit simpler. I would love to connect with other women going through a similar stage of life. Does New Life have a forum for this to happen? The answer is yes. We're working on it and developing it as we speak. Are additional checks in PGT, such as for blood conditions, at an extra cost, or does the price per embryo include all testing required? So if a person has PGT testing just to check the chromosome count, there is a specific price per embryo for that. If someone has a test that's done for a specific genetic condition, then that test is usually quite tricky because quite often it'll be an individual genetic mutation that may be unique to that family. And so there will usually be a cost in developing a test for that family, to be able to do the testing. And then once that test has been developed, there will be the ongoing cost per embryo for that. If unsuccessful in one cycle, can you do back-to-back cycles, or is there a wait period? Nicole mentioned earlier that it is possible to do back-to-back cycles. We can do this both with stimulation cycles and also with embryo transfer cycles. So it is possible. However, some people are very keen to do that. Other people find that sort of on an emotional level, they need a bit of a break between the cycles just to sort of get their head together and get their head around what's happened. What's an appropriate BMI range and what may be too high? So the answer to this is the best BMI range that we would want to see is people in the normal range, and that's a BMI between 18 and 25. Going up from there people get more health issues. Going down from there, people get more health issues. And with regard to IVF, generally that group is the group that get the best results. I'll hand back to Nicole.
Okay, is there a price cap for PGT-M on testing for individual embryos? Yes, there is. It is 3,950, which off the top of my head gets you is at 6 embryos or more. Does that sound about right? Yeah. So if you do have 8 embryos, you are charged for the same as if you had 6 embryos. Now, if you are doing, I don't know what Steve is, but if you were doing PGT-M, the cap is a little bit higher. That's for 500. So the 3,950 is for doing PGT-A, which is the chromosome testing, and the 4,500 is for the PGT-M, which is looking for genes. So what sort of side effects might we expect from the medications? They are hormone medications, so I think anything you can think of that you might put under the hormonal side effects, you can get with the IVF medications. So that might be fatigue, maybe some headaches, maybe a bit moody, short temper, teary, and definitely, hopefully you will feel a bit of bloating and abdominal discomfort as you get your eggs growing as well. Now, having said that, even though people do experience these sort of side effects, usually they are not severe. I know there are movies and TV shows which show people going absolutely crazy on IVF medications, but the reality is most people are aware that they're taking hormone medications, but they are still doing all their activities and living happily in their home without tearing everyone's hair out and going crazy. So definitely you'll be aware you're on medications, but it's not as bad as things are led to believe in the media. So I want to thank everyone for attending, and to thank you also for submitting all those questions. We've had a lot of questions tonight. You've definitely kept Martin and I on our toes. For those of you who want to listen to the webinar again, or who are interested in some of the other webinars that we've done, we do have a New Life YouTube channel, and this webinar will be added to that, and all the other webinars are there as well for you to watch at your leisure. Our next webinar is going to be in a month, so that's going to be Tuesday, 8th of September at 6:30 p.m, and that is going to be given by the delightful Dr. Samir Jakkar and Dr. Amber Kennedy, and they are going to be talking about egg freezing. Is it right for you, and what's involved? So they'll take you through that. So once again, thank you for listening and participating. That's been fantastic. Now Martin and I have to leave to get home before curfew, and we will be seeing you for the next webinar down the track. Thank you.
Thank you.